Okay, I see the light at the end of the tunnel, and it's an oncoming train. All right, so we are managing side effects. I don't know why you need to talk about side effects. What kind of problems do you get? So joining me will be Gwen Huitt from National Jewish, Ted Marras from Toronto, Canada, and my personal favorite, Julie Philley from Tyler, Texas. So, Gwen, are you up first?
No, Ted's up.
Oh, Ted's up first.
Well,
you're from the entire province. Did you know that? Covers all of Canada.
So thanks for the gracious introduction and advising, reminding me that I cover all of the province of Ontario, and in 6 minutes, I'm going to try and cover these 4 classes of drugs. First, I have to show this slide that Gwen inserted at the start of our combined slide deck, and I think this is a really important message, and I think this is the message from our combined presentation. So 6 minutes on the macrolides, azithromycin, clarithromycin, ethambutol, rifamycin, rifampin, rifabutin, fluoroquinolones, moxy, cipro, and levofloxacin. And for sure, I won't be able to talk about drug interactions, but hopefully we can do so at a discussion point later. So macrolides, the cornerstone of therapy for MAC, and really critical for treating susceptible M. abscessus isolates and numerous other NTM species. They're usually quite well tolerated. Most people have some adverse effects from them, much more so with clarithromycin than azithromycin. And by far and away, most common is the gastrointestinal issues. Many patients, some patients, maybe I should say, get diarrhea, some get nausea, abdominal pain, etc. Much more so with clarithromycin. So selecting AZ is probably a better choice up front. And working with your provider to think about strategies to reduce or manage these is really important. Taking medications with food, considering the addition of a probiotic, making adjustments to your diet, dosing, schedule adjustments to the dose, not to suffer with side effects. One of my patients recently, when I saw her at a routine follow-up visit, who always told me she was doing well, and then she outed herself and said, well, about 2 in the afternoon, I have to lie down because I have really serious abdominal cramps and they last for about 3 hours every afternoon. And she'd been sort of accepting this as part of treatment. And I thought I was doing a good job in her care, but clearly I was not. So that's not acceptable. We need to work on strategies to relieve those symptoms, and that can be done in almost all patients. I wanted to touch on hearing loss and tinnitus with macrolides. It's described as occurring in less than 1% of patients. I think it happens a little more commonly than that, especially when we use higher doses. But if we suspect it's there, we really need to be thorough about objectively documenting it with hearing tests and figuring out what to do about it. The good news is it is usually at least partially reversible. I'm not talking about the grayed out areas, but hopefully you'll have this information subsequently to review, and you can read more about the other adverse effects. I do want to mention the issue of sudden cardiac death with macrolides that was touched on earlier today. It has received a lot of attention, and the thought is that because macrolides change the electrical conduction in your heart, prolong this QT interval on the electrocardiogram, makes us more susceptible to a fatal arrhythmia. Now, this is really rare. This large, huge Tennessee Medicaid study found that it seems to occur perhaps in 47 out of 1 million courses of azithromycin, so very rare. In this national Danish study, they found no risk of sudden death from azithromycin. Probably there is a very small risk. The Danish study had slightly younger patients. So for older people who have heart disease, especially, we need to think about getting a cardiogram before starting, getting one, repeating it after starting, thinking about other drugs that may prolong the QT interval, but not to panic and avoid treatment because of this very rare, albeit catastrophic event. Ethambutol. It is, I think, the most important agent to prevent macrolide resistance in MAC lung disease. And standing beside Dave, I have to say that this is really important. The role is less certain in other NTM species as to how much of a role it plays protecting the macrolide, et cetera, but I think we still use it very commonly, and we think carefully about the one toxicity that is most important from ethambutol, the optic neuropathy or vision damage. It can cause blurriness, it can cause blind spots, it can cause color blindness, and although if it's stopped early on in the toxicity, usually those are reversible. If it is continued despite the onset, it certainly can cause irreversible and severe visual loss. The chance is greater with high daily doses, like above 17 to 20 milligrams per kilogram daily, much lower with the 15 to 17 milligram per kilogram dose, maybe about 5% or a little more than 5%. And if we use the thrice weekly dose like we do in typically in non-cavitary MAC lung disease, probably only about 1%. So we try and avoid a high daily dose when we can. I encourage patients to test their vision every month, do their color vision and their acuity online. There's several good websites where they can do that, see their eye care specialist regularly, and if they develop problems with the vision, to withhold the ethambutol, call me right away and see their eye doctor right away. We need to document objectively what's going on, and we need to avoid risking irreversible damage to the vision. Rifamycins, both rifampin and rifabutin, very commonly used, one of the 3 frontline drugs for MAC, and also very commonly used for several other species. Very important interactions between rifampin and other drugs, so that's bad. On the other hand, rifabutin is less well tolerated, so that's bad. They both make your urine turn orange, which is maybe interesting, but that disappears when you stop the drug, and it's not really what I would consider a toxicity. On the other hand, gastrointestinal-related symptoms are fairly common, and certain strategies can be employed, like with the macrolides or when you have GI toxicity with ethambutol or other drugs. Systemic issues, flu-like symptoms, rashes with joint pain and swelling certainly can occur, and some of these can be very severe, and we need to address these issues, make sure you bring them to your attention of your provider right away if you're experiencing a new constellation of side effects. And then finally, liver inflammation and low blood counts are not common, but they occur in a minority of patients, so I think it's important that we do periodic blood work to detect them before they become severe and manage that issue if it arises. And finally, fluoroquinolones. Relatively commonly used in NTM lung disease, and the complaint I get most from my patients is gastrointestinal distress. And a lot of strategies we can try to work around that may be similar or at least analogous to the strategies with the other drugs. Musculoskeletal pain, aches and pains in the body, I find more problematic. I think, at least in my experience, fewer patients complain about that toxicity, but I find it more difficult to manage and more likely to have to interrupt the treatment with this class of drugs for that reason. And finally, drug interactions. Since no one's pulling me off the stage, I will mention again that rifampin very commonly interacts with many drugs. It induces our liver to metabolize drugs more quickly, so many medications will be cleared from the body faster, so they will be less effective. Maybe our blood pressure medications, maybe our cholesterol medications, maybe our other antibiotics for our MAC lung disease. So when we're starting rifampin, we need to carefully review all the drugs and figure out where we need to be more vigilant to look for changes that will dictate dose adjustments in other drugs, your thyroid medication, your hormone replacement. Clarithromycin, on the other hand, impairs or reduces the liver's metabolism of various drugs and may increase those levels, leading to toxicity. Yet another reason to choose azithromycin instead. And then other drugs that are commonly used in NTM lung disease are can have interactions, antifungals can affect drug levels, and many drugs that are prescribed affect the QT interval on the cardiogram and need to be considered when we're using macrolides and maybe other QT prolonging agents. Thank you.
Hello, thank you for having us. My name's Julie Philley. I work in Tyler. I've made a lot of mistakes in my life, but I chose to marry the right man and chose to work for the right man. I really will always thank Dave for giving me a job. I've loved working with Dr. Wallace and Dr. Griffith, and the jokes have been the same, and they continue to practice. I don't think they'll ever improve, but I, too, always enjoy when Dave moderates. I said all of that with a straight face, because it's true. I'm going to talk to you a little bit about inhaled amikacin, IV amikacin, bedaquiline, tedezolid, and linezolid. This is going to be completely patient-centered, so if you haven't heard of these drugs or if you haven't been on these drugs, it's okay to ignore these. But I wanted to talk to you a little bit about inhaled amikacin. Historically, we've used inhaled amikacin, which is an antibiotic that's put into a nebulizer inhaled off-label, meaning many of you or some of you have even drawn it up from a vial that was originally used to be given in the vein, put it in a nebulizer, and inhaled it. And in fact, many of the early studies, especially done by Dr. Olivier, Dr. Ruas, and others, showed some efficacy, or that this way worked. And so we were very excited when a new formulation came out and was approved by the FDA, as you already heard in the fall, called Arikayce. And that's a different formulation of inhaled amikacin, which is delivered by a different nebulizer. And I apologize for the small picture, but it's put into what's called a Lamira nebulizer, which is a special nebulizer that can deliver this particle of inhaled amikacin that's wrapped in a water core or a lipid core that is better delivered to the area or to the cell where the MAC lives. And studies have shown that there's better uptake into the cell, thus we think better killing of the bacteria, and you already have seen that that has actually shown to be effective. But what about using it? What does it mean to use it? I'm not going to go over with you the package insert of every single thing that was ever reported with this drug. I'm just going to talk to you like I talk to my own patients. What I'm going to tell you is that if your doctor puts you on this drug, you are going to experience some cough. I anticipate that you'll experience some changes in your voice or maybe even some throat irritation. You may have some tightness in your chest or bronchospasm. Some people have coughed up blood with this drug, and some people have had ringing in the ears. This is usually tolerable if you expect it to happen, and I do anticipate that this will happen with people that are on it, and I'm sure people actually in the room that have taken it have experienced the same thing. There are some tips for taking inhaled antibiotics, Arikayce or off-label inhaled amikacin, or other inhaled antibiotics for that matter. You can use a bronchodilator like albuterol ProAir, there's many names for these, before you use the medication. If you take hot tea or other warm liquids, sometimes that will soothe the throat and make people feel better. But I think the biggest tip that I tell people is you have to practice a little bit of patience, and you have to understand that you will experience these side effects. Typically, the more you use it, the better it gets. That does not mean that if you experience terrible chest pain, can't breathe, can't get up and walk to the next room, that you should continue. You should notify your doctor. But if the side effects are tolerable, what I usually tell people is that within 4 to 6, 8 weeks of use, this usually improves. Sometimes we can even hold the medication, hold the inhaled antibiotics for a few days and introduce it more slowly or intermittently, and we can usually get people through by taking medication in a different way. The use of intravenous amikacin, some of you in the room may have had what's called a PICC line or an IV line inserted into your arm, and you may have been on intravenous amikacin, and Dr. Huitt will go over other antibiotics that can be given intravenously. The side effects that are most common that we worried about with intravenous amikacin are hearing loss, damage to the kidneys, nausea, and any antibiotic can cause rash, among a variety of other things. With the use of inhaled amikacin, we believe, specifically inhaled versus intravenous, that with inhaled there is much less toxicity. Intravenous amikacin, I do tell people I anticipate you are going to experience some hearing loss. it is usually starts, especially as high frequency hearing loss, and that's why it's very important that you check your hearing tests often, notify your physician if you experience these symptoms. Sometimes differing doses can be reduced and other tips can be administered, but please let your medical professional know should you experience these symptoms. Moving on, especially for the sake of time, to bedaquiline use. Bedaquiline is a drug maybe many of you have not heard of. The other name for it is called Ceturo. The FDA approved this drug in 2013 for drug-resistant tuberculosis, which is a big problem in the world. Fortunately, some studies have shown that this actually works for non-tuberculous mycobacteria too, especially MAC and abscessus. Ceturo is not available at CVS or Walgreens. If your physician puts you on this, it is usually a specialized physician, usually one that deals with NTM. This is available in one pharmacy in the United States. We've had the most success of obtaining this drug if your insurance approves it. You take it with food. For the first few weeks, you take an increased dose. That's when, in my experience, we've seen the most side effects, and that's followed by 200 milligrams 3 times a week. The side effects with this type of drug, when they're present or if they're present, is usually GI related. In my experience, it's nausea, vomiting. We definitely want to watch liver enzymes. And then in certain patients, you can have a change in the electrical conduction of your heart, and that's specifically a prolongation of what's called the QTC interval. And so we monitor your heart rhythm with electrocardiograms. Certainly headache, rash, and joint aches have been also described with this drug. So to that effect, if you're on this drug, I let patients know, please tell me or don't take any more of the medication if you experience chest pain, palpitations, if your skin turns yellow, you have a rash, you have a severe headache. And I would think most NTM providers would agree that if you experience debilitating symptoms on any drug, it is generally safe to hold the medication until you've spoken with your physician. I've already gone over this portion. So just to wrap up with other drugs that are less commonly used in NTM, but many of you may have heard of them, Tedezolid and Linezolid, Zyvox and Cevestro. These are in the same class of medications. They act in a certain way. They were not developed for NTM, but do have a place for treatment in some situations. The side effects of these drugs are immense at times, and let me explain that. Many times these drugs can cause changes in your blood counts such that you may have a low white blood cell count, low platelet count, among other things. And many patients who take these drugs have described numbness or tingling in their arms or legs, which we define as neuropathy. And many times this can be debilitating and can cause people to have to stop taking the drug. There are also other changes that can occur with these drugs, and many times when we use these drugs in NTM, and specifically the studies that have been published, have used these drugs at lower dosages than what's in the package insert. So if you are on one of these drugs and it's lower than what the package insert says, sometimes that is intentional. Just talk to your physician about that. It is important to monitor your blood work and to notify, again, your doctor if you have any strange symptoms. And I think when people are on a multitude of drugs, sometimes we have a pulmonary problem or a lung problem, and you think, well, I'm not sure why I can't walk now. Surely I now have a neurologic problem, and I need to see a neurologist. And it can become very confusing. And that's when we have to try to do the best we can to educate people to say, always blame the drugs first that I have you on before you start to seek other professional opinions about other diagnoses which simply may be related to the medications that you're on. And with that, I'll invite Dr. Huitt to finish our discussion on side effects.
Okay. You know, the first thing I have to say is, I remember a meeting that, and Dr. Wallace, you'll probably remember this, that we had in like 1994 up in Vail, Colorado, and it maybe had 20 people there. and that was the first kind of NTM gathering of clinicians and scientists. And to see how that meeting has now morphed into something like this with both physicians and patients and researchers just warms the cockles of my heart, I will tell you. Okay, so I wanted to start my portion off with clofazimine. We administer a lot of this medication. I think probably there's 3 of us in the room, Dr. Wallace, Dr. Griffith, and myself, that are still practicing medicine that used to use this drug as part of the standard treatment regimen for MAC when we all started practicing in this field. And when you read everything that's online about what can happen to you if you're taking this medicine or if you're applying for it and are going to administer it, yes, certain things you need to watch for, but I just put some illustrations up here of the most common thing that occurs, and that's skin discoloration. And this medicine is a brown, gooey liquid that has a pigment in it that is very fat, has a fat affinity, so it deposits in the fatty cells of your body and will gradually accumulate, and in some people that are darker skinned will accumulate and manifest the dark skin a little sooner than others, but we can always cut back on the dose. So I'd say that's the first and foremost thing that we experience. And a couple of the pictures on the right are a gentleman who is a Pacific Islander, and you can see he has very splotchy brown areas, and I just stopped his medication. The bottom picture is after he'd actually been off the medication for about two months. The middle picture is a woman who's Native American, and she accumulated the clofazimine quite rapidly. We cut back the dose, and she was fine. The other gal on the left is kind of I've had women beg me not to take them off of clofazimine because they liked the healthy look that it gave them. I mean, that is absolutely true. It's a new old drug, and from the clinician standpoint, I would say the biggest thing that we hear from our colleagues is what a pain in the behind it is to get this drug for many of their patients, because the process can be quite onerous if you don't have the right procedures and groups in place. So if your doc is going to bat to get this drug for you, hats off to them, because it's not so easy. It can be quite cumbersome, and once you get the paperwork in, it can take another month or so to get the drug from the company, and right now it's free from the company. We start the dose at 2 pills a day or 100 milligrams a day, and as I said, the biggest problem is the skin pigmentation issue, but gastrointestinal complaints can occur. I think they're very rare overall, but you can also have, the other big complaint I've had from patients is if they tend to be a dental plaque kind of person, I've had people have to get their teeth cleaned every month while they're on clofazimine because they get a dark hue to their teeth, and it's just the plaque on their teeth that is discolored. We also get a baseline ECG, a cardiogram that was alluded to earlier on other drugs. We have to do this for this drug as well to look for what's called the prolonged QT interval. But again, simple thing to do. Overall simple drug to administer with overall very few side effects, except if you have dark age spots like I do. They will never go back to their normal color if you're on clofazimine, so you'll have darker age spots. Any of these drugs will cause and can cause a rash. I honestly have never seen a rash to clofazimine in my career, but basically everything else that we give can cause a rash. So that's always part of the disclaimer of any drug. And I want to say one of the things, too, about these next 2 drugs that I'm going to talk about briefly, they're both intravenous. And one of the side effects, we're talking about medication side effects, one of the side effects outside of a drug side effect is how does the patient and the physicians coordinate care? Once Once you're considering an intravenous drug, at least in the States, we often involve an infectious disease physician along with your pulmonologist. So you've got to, it's like herding cats sometimes, to have two doctors in your stable of caregivers trying to coordinate care. You have to have some type of intravenous access placed, and then if you happen to be in Medicare age, you have to somehow find how you're going to be able to get this drug administered to you. So as far as I'm concerned, those are side effects that we don't talk about because they create mental angst for everyone, and potentially physical angst, actually. So imipenem silastin is a drug that we give for the Mycobacterium abscessus, or the rapidly growing mycobacteria group of organisms, as well as Pseudomonas. And the big thing to remember is it obviously can cause a rash. It can cause some inflammation in your liver. It's what's called a broad spectrum antibiotic, so it can cause a diarrheal syndrome, which can be severe. So be sure you don't wait and let your caregiver know you're having a problem. Whatever the problem is, you need to report it because we need to help you fix it. It is administered with a PICC line, just as the next drug that I'm going to talk about. We usually administer it twice a day. Oftentimes, I will say, let's give it Monday through Friday only, because if you're a Medicare patient, many infusion centers are not even open on the weekend, so your ability to even have these infusions done on the weekend is limited. And we, in the Infectious Disease Society realm, need to work with insurance and with Medicare to try to change those rules, actually. The last thing I want to talk about imipenem is, for the practitioners out there, Meropenem can be substituted. It's relatively as active as imipenem, but Doropenem and Ertapenem, which are once-a-day drugs, really have minimal activity in the cocktail regimen that we traditionally use, so don't substitute those. And if your patient says, I feel like I want to die every time I get an infusion of this, listen to them and stop the medicine. They're having a drug reaction, and you can get a C-reactive protein or other inflammatory markers, and oftentimes I've seen huge C-reactive proteins, and they're having a drug reaction, and when you stop the imipenem, they will feel like they're not going to die. The last antibiotic that I've been challenged to talk about is Cefoxitin. This is probably the antibiotic that I've had that causes the most rashes. We tend not to use it as much anymore because imipenem doesn't cause as many rashes and doesn't cause as many problems, but it can be utilized in treating rapidly growing mycobacterial infections as well. And just as an aside, when rashes would occur with many of these patients, we would desensitize them. We're trying to fool the immune system to accept the drug, and usually we could get another month or so into the patient before the rash occurred again. So it traditionally is not a durable desensitization, but if you're trying to eke out a few more weeks of the antibiotic, you can try that. And the diarrhea is another problem that you've got to watch for closely with both of these two intravenous medications. And regular monitoring of blood counts and liver tests must be done with both of these drugs to make sure that we're not causing some problems. So there I am.
Thank you.